Okay. Uh, First of all, I'm thankful to all of you for Teachers' Day messages that I got. Uh, my whole day has gone in replying as much as I can. And it's so nice to be part of this group where there are people willing to learn. And like they say, when a child is born, a mother is born. Uh, like that, only when we have students, we can become teachers. And it's an honor to be part of this group, which still continues to be passionate about learning. Now, coming to this topic, clinical medicine, is it the beginning of the end? It's a question that's haunted all of us for the past 1 or 2 decades, where we are beginning to see a lot of investigations come in. And it does make us question this concept whether clinical medicine is something in the past. So I have been trying to analyze 45 years of clinical experience to look at this question. All of us have to pause at some time and examine our lives. Otherwise, the unexamined life is not worth living. That applies to life and career and work and everything that we do. This pause is needed. The stepping back is needed. And that's what I've tried to do in this lecture. This is a lecture that I delivered in Manipal recently as an oration for physicians and students. And we'll go about it in the following headings. What is the current status of clinical medicine? What are the fallacies of clinical medicine? Can investigations replace clinical medicine? And will clinical medicine survive? We'll try to answer each of these questions one by one. Now, let's look at the current status of clinical medicine. Most of clinical medicine is like magic. It evolved in the last century and it gave us the first peep into the diagnosis. And it did it in a fantastic way with only our eyes, hands, and ears to make the diagnosis. And very few instruments we still have, like a stethoscope, a knee hammer, and some few things like that, one tuning fork, all of which can be carried in the coat pocket. And I don't know whether you recognize any of these people. Uh, Most of them we actually know. That is Babinski, that is Lenac, and there is Orberger. Each of them has contributed in a major way to the clinical examination that we do now. I think Babinski's name we take every day, and most PGs in the exam are always worried whether the plantar will go up when the examiner comes. I have seen some of them telling the patient, when I stroke your sole, please lift your toe a little. That's the extent at which Babinski has ruled our lives all through. And of course, we know Lenac made a huge difference because of the auscultation. The last class we had on cardiac auscultation. All that came because we invented the stethoscope. And it's a miracle that we learned to interpret so much from just listening to the heart and to the lungs. Hornberger is a fantastic observer of the percussion note, where he used percussion to find out how much is the wine that is present in the caskets in the farmhouse, and that's how he got the skill of percussion into clinical examination. So, in many ways, it's actually very fascinating that just by using small things, we could come up to a diagnosis. We could say this patient has a mitral stenosis, that patient has a pneumothorax, that one has a hemiplegia, and we know where is the lesion. All these questions we were able to do with just clinical examination. Now, clinical examination begins with history taking. And if you listen long enough to the patient, he will tell you what is wrong with him. Listen to him, he's telling you the diagnosis. This was a quote from William Osler, the great physician, who you will find many such quotes from him. And I think it is very, very true that history taking makes a huge difference to the arrival of the diagnosis. And this is probably the most disrespected and unused skill as of now. Do we take a good history? The average American physician interrupts his patient every 14 seconds. I think we interrupt every 2 seconds. That is because the art of listening has gone. We hardly listen. We want to have that checklist of questions being answered by the patient. Did you have chest pain? Where is the chest pain? Where did it go? What respirated? What do you feel breathless? And then in that confusion, the patient has so much to say that he has completely forgotten what he wanted to say. And this is the age of fast forwards. Everything you want to be done fast, and in that, a lot is missed. And that is how the history is often not taken very well these days. Now, can we take a good history? That's another question. Because if you're working in a government hospital, or if you're working in a crowded hospital, there are so many patients there, and whether it is possible to take a detailed history from everybody is a question, is a moot question. But I think a sincere attempt must be done to kind of ask what is happening. Otherwise, we will definitely miss something in the diagnosis. One of the laments that I've heard from PGs is, he didn't tell me, madam, he's telling you. Now, why does this happen? Because history taking is an art. Years of experience are needed to take a good history. And that is why you will find that the patient suddenly volunteers some new information and makes it embarrassing for you as a postgraduate in front of his seniors, in his assistant professors and the professor. And everybody is thinking you don't know how to take a history. The point is that there is a way of doing it. And that, if you ask me, it's a 10,000 hours. If you have read this brilliant book called Outliers by Malcolm Gladwell, he talks about any skill that you need in life. If you have to master it, you have to spend 10,000 hours, like playing a violin, mastering tennis, speaking at a public forum, teaching, or even a history of, the art of history taking. I think all these require repetition. And if you do not repeat, and if you do not go and do and put in that work, you will never get the ease with which the experts will be doing it. So please don't think that we are any more intelligent than you. We just completed our 10,000 hours. The examples of a good history, some of these stories, many of my postgraduates would have heard many times, but these are good ones, so I think I don't mind repeating it. We had a 56-year-old factory worker with PUO. This was in Manipal. No major history or examination findings. He has gone around the whole place investigating for his POO, and all fever negative. Everything was negative. Cultures, body fluids, everything was negative. He was posted for a CT scan of the thorax and abdomen as a sequence to the next step in the diagnosis of a PUO. And when they go to radiology, the radiologist is always terrified about contrast allergy. So he always asks the patient, do you have any allergy? I find sometimes I have to tell the patient to say, I don't have allergy, because otherwise if he sneezes there, he gets into one steroid protocol there, and the CT scan is postponed, and they say, load him with steroid, otherwise we won't do. But this patient obviously sneezed in that radiologist's place, and then his allergy protocol was followed, and his fever disappeared, and patient was well. The next time when I went for rounds, the patient was happy, sitting there and saying, very happy, saying that he had no fever. We all know that steroid is a whitewash. Steroid can get rid of any fever, and many general practitioners use steroids just to get the time to make a diagnosis. Otherwise, the patient will be always asking, what is wrong with me? He will want to jump to the next doctor. But in this patient, we discovered that he was swallowing Dexona regularly for some aches and pains. It was given to him long time ago when he had a post-viral arthritis or something, following which he never went back to anybody. He found this drug to be some magic cure. He was very happy with the drug, and he continued to take it for years. And for some reason, during a trip or something, he discontinued it. And somebody told him, oh, it's a steroid, you should not take it at all. And then he discontinued, and he presented to us as a PUO. And it was discovered when we found out, when the radiologist gave the steroid, and this man bloomed like a flower. That is when we discovered it was a steroid withdrawal. And after that, we have seen many, many cases of steroid withdrawal presenting with all kinds of symptoms. This is another common story that I talk about, which is a funny story, so I don't mind saying it again. We had the deaf old man whose deafness was total, and ENT found nothing wrong with him. He came in for some gastroenteritis. He was admitted outside. And then 2 days in that nursing home, he said he went totally deaf. We thought they had given him amikacin, they had given him something which really destroyed his this thing, but we never found anything much. There's no aminoglycoside and there was no vestibular symptoms at all. And we were wondering what happened to him. And one crucial question we forgot to ask was, since when? We had all assumed that he is deaf like that. But the crucial question was, how long? It was only 15 days. So this man was admitted in a nursing home 15 days ago for a gastroenteritis, and then he became deaf in that place instantaneously in the nursing home, not after giving anything. And what did we miss? We missed this. This is Yama coming on his chariot there, and he's trying to come and catch this man. What happened was this man was admitted in a nursing home, and 2 people on either side died that night. And he was very scared. He was terrified because he was alone in the ICU. He was on fluids, and he felt that the next person to go up would be him. And Yama was coming and sending his Yamadutas and saying, come with me. And so he told them, no, I can't come because I can't hear you. I'm deaf. This is what happened. And after that, he said he's deaf. So he wanted to avoid these Yamadutas coming after him. And he said that he himself is deaf and would not listen to any conversation. Now, this we discovered after history taking, and then we let the old man go, telling him that nothing is wrong with him. And we have sent away the Yamadutas. So this is another example of how history is so crucial. Now, history is important, especially in a seizure. A seizure never happens in front of you. Most of the time, it's a history. How do you make out it is a seizure? I mean, that again takes time to understand, and you have to get the bystander, and that person has to tell you. Now, this is important because if it's a seizure, you have to treat. If it's an idiopathic epilepsy, you'll probably have to treat 2 to 3 years. Now, you wouldn't go and put that on somebody who doesn't have a major problem or somebody who's hysterical. So, this history taking for a seizure, whether there's an incontinence, whether there's a head injury, whether there was a tongue bite, all these things which make it definitely organic rather than functional is very important. And one of the questions that we ask the person who is involved in the seizure, the patient, is that, could you hear everything that's happening around you? Remember, a GTCS causes loss of consciousness, so you normally shouldn't be able to hear anything. But people who are malingering would say that, yes, I could hear what he was telling. So some of these small things would make a difference to finding out the diagnosis. Many times hysterical seizures or hysterical behavior happens in areas where there's an audience. So you do it in front of somebody for a secondary gain. So the attention-seeking behavior is again coming from the history. Many patients who are anxious, will either belch continuously, or they will, take a deep breath and say, this is how I feel that I'm not getting enough air. So I actually take a very deep breath. And you see any number of these patients, once you see them and you understand it's anxiety, it's easy to recognize the next patient. So this deep breath phenomenon is again suggesting anxiety, comes from the history. Many times we do not focus on the patient's mental status when we talk about sugars. I can never forget a mistake I made in my life where I shouted at a lady for having very uncontrolled sugars without understanding that she lost a close family member 15 days before I saw her. So I felt really miserable trying to tell her that, what did you eat? Did you have sugar? And things like that. When I never really asked, what is your mental state? Hardly anybody asks a diabetic patient whether he's feeling stressed. And we all know that stress contributes to sugar. And I've seen this happening many, many times in life where it goes up to 400 after some stress. and happily comes down when the stress is gone. But how many of us take that history? Now, going on to examination, is examination important for the clinical medicine? Now, where examination gives the diagnosis without much investigations, I had this 65-year-old lady who was diagnosed as periarthritis shoulder, and she was sent from the orthopedician to me, saying that now her chest. That is why he sent to me. He referred as a case of chest pain, but she went to the orthopedics for a periarthritis shoulder. And what we found when we stripped her blouse was the herpes zoster. So this is something that many times we examine patients without stripping them and without seeing where the problem is. If you see where the problem is, many things are very obvious. Like I missed a gibbous in a patient who was complaining of backache. And, once you see the gibbous, you know your diagnosis. If you've got a 2 months history, that's a tuberculous spine, that's a pot spine. So many small things will give you the diagnosis in one shot without much effort at all. Again, I think I have told you the story of a 50-year-old lady with ongoing fever and abdominal pain admitted in the surgery department. Investigations, LFT was mildly abnormal with an ALP elevated. They investigated her right up to MRCP. And only when that was normal, a medicine consultation was given for an ongoing fever on meropenem. Nowadays, we don't stop with ceftriaxone, we don't stop with piptas, we have meropenem, and unless we give meropenem, none of us sleeps, isn't it? So this happens to all of us. And what we found was a nice small eschar in the inguinal region, which was the diagnosis all through, and a few days of doxy, and she was fine. So again, clinical examination could have given the clue, could have saved this lady 1 week of stay and so many investigations. I think she lost a lot of money in this whole rigmarole. So physical examination is a dying art. And this article came out from Armed Forces India Journal. And again, William Osler says, he who studies medicine without books sails an uncharted sea. But he who studies medicine without patience does not go to the sea at all. So if you think that by reading Harrison, by reading a textbook, you can master medicine, you're completely wrong. Okay? Because without a patient, without understanding what is going on with the patient and without seeing patients, we will never be able to make a good diagnosis or become a good doctor. Now, where clinical examination is crucial, I would like to put across one case that we came across in VHS. It was a 48-year-old male underwent angioplasty for IHD at a government hospital nearby, came with fever due to an IV line. Line was removed, and we thought that's a cause of fever. It should have gone, but fever persisted. One day on rounds, I observed he was using a urine can at the bedside and sitting near the bed and urinating. So I asked him, you only have fever. Why didn't you go to the bathroom? Then he said he was breathless. ECG was normal, chest X-ray was normal, echo done twice outside in the government hospital was normal. Everything else was normal except a mild upper limit TC. Now what? This is when you're stuck, you go back and retake the history and re-examine. When I re-examined, we found that the BP had not been recorded correctly, but it was actually 140/80. Clinical examination, there was no cardiomegaly, but there was a beautiful ejection system, early diastolic murmur in the second aortic area. And we wrote to the echo room saying, please look for an AR. This was our echo room, not the outside. And there was a moderate AR detected with vegetations on the valve. Now the question came back to us, why was the echo normal twice? Please remember, the echo is not God's word. That something should be believed always because it's written in the echo. Maybe the echo was done early, not seen correctly. Maybe there was a poor window. Maybe the technician missed. Remember, you're not doing the echo. It's not your word. And you're as a clinician, you're only making a diagnosis. And depending on the technician, somebody would have missed. Or patient developed ER later. And remember, you can't do an echo every day. We cannot do this every day. whatever be your investigation, it cannot be done every day for you to be comfortable that the heart is normal. So never hesitate to re-examine. So this patient turned out to be a patient with infective endocarditis. Now let's look at the current status of clinical medicine in UG and PG training. We are using it in UG and PG training and UG, but it is losing its importance. Now, let's take a step back and look at what we are insisting on clinical science. This is a famous statement from George Orwell in the fantastic book called Animal Farm. All animals are equal, but some animals are more equal than others. So this is his concept of what we define as equality. So let's look at, are all clinical science equally important? Now, one is this inch tape that we are insisting that people should use to measure the chest, to measure the drooping of the shoulder, etc., etc. In some places, it is very important. For example, the abdominal girth. Definitely good to have an inch tape and measure. The surgeon needs it for finding out whether there's a perforation, whether the abdominal distension has subsided, etc., etc. But in respiratory system, maybe we should rethink whether this is needed or not. The American Medical Association was drastic. They held a funeral service for physical examination, and you'll be shocked to say what they wrote. Of course, this is a spoof. This is not their idea of what clinical medicine should be, but they gave this list. Look at that list. S3, S4 murmurs, palpating the point of maximal impact, percussing the lungs, and it goes on and on. And look at the last part. Any part of the exam where human contact is involved is something that they don't want. The American Medical Association said this should be a funeral service for any of this. Of course, it is written in jest. It is not their conviction that this should happen. So let's look at, do they help to make a diagnosis, this clinical science? So another case that I'll show you, a 45-year-old man came with recent onset breathlessness on walking, and he was on treatment for anxiety. And this is where it went wrong for us. He had a heart rate which was high, and respiratory rate, we thought, because he was anxious, became more breathless. The only thing we observed is walking from the chair to the couch in our room, he became breathless. And then we heard an S3 gallop, RBS3. So the diagnosis became pulmonary embolism. So I want to thank S3 publicly for helping me to make this diagnosis. So obviously, I wouldn't hold a funeral service for S3. So the Stanford 25, which is from Stanford Medical School, which lists the number of things that are actually useful in clinical examination. And this is a good list to look at. So if you go through this, you will find that many of the things that we are usually doing are useful. This is an undergraduate level kind of thing, but you can go through it it's available in the net and you can go through. So what I'm trying to say is that maybe not all clinical science are important, but definitely there are some that are very, very important. Let's move on to the other aspect where investigations win. Let's play the devil's advocate. Now, this was a person, a middle-aged lady with hemoptysis with no clinical findings, and the CT scan beautifully showed right upper lobe cavitation. Now, why did we miss this cavitation? Remember that your stethoscope cannot reach beyond 5 centimeters into the chest. If you have an obese person, you're not going to be auscultatively, you're going to be deaf to whatever happens at a depth. So remember that investigations can show you things that your clinical examination may not be able to pick up. I remember a debate from my days in Stanley Medical College when we had a cardiology professor from Texas University. He worked there for 14 years at that time, and he had recently migrated to Chennai and joined our cardiology department. And he had a debate with our physician in what we used to call as a clinical meeting, where cases used to be presented and discussed. The physician made a diagnosis, my professor, my medicine professor, made a diagnosis of moderate MS, mild MR, etc., etc. And the cardiologist was saying, no, I won't believe any of this, I need the echo. And this debate went on, and those were the early days of echo, where we never really understood that, it could show much more. The point is that echo has made a difference to the diagnosis of many, many conditions that we have. But please remember, there is another side to it. When I tried to go for an eco training in Hyderabad, I sat in the eco room for nearly a week and tried to learn eco. And I did learn and I did do ecos where I was working in Udupi Hospital. I found two cardiologists arguing. One showed me the probe and told me, see, madam, this is mild mitral stenosis. And the other man came and said, what mild? This is severe. He only turned the probe a little differently. Now I realize that these people can make you believe anything because they are looking at a probe, they are looking at the mitral valve at different angles. If you cut something at different angles in a picture, you can get a different dimension. So again, a lot depends on who is doing your echo and how he is holding the probe and what is his, his interpretation of those findings. So remember that there can be another side even to the echo. MRI, we know, has transformed neurological diagnosis. Where we used to analyze, and make a diagnosis, the MRI gives you in one shot. You can see the beautiful Wallenberg sitting there. So easy, isn't it? So that's why we are all tempted. Okay, we don't know what it is, go and do an MRI. And the chest X-ray again shows you the diagnosis. Many times, tuberculosis can be easily picked up on a chest X-ray. So maybe because our daily lives are crowded, easy way out is probably investigations. You investigate and then you can finish it off in one shot instead of breaking your head with so much of clinical examination. So were we ignoring investigations and clinical training? Our exam cases had only findings. Mitral stenosis in the exam hall, but not ischemic heart disease, whereas ischemic heart disease in the outside world was more than 95% of our practice. Hemiplegia was kept in this thing, not seizures, where seizures was probably very important for us to make a diagnosis. So actually in Manipal, we changed the exam. We did the course correction. We started putting cases in the UG and PG exam called therapeutic case, where the diagnosis was given to you. We told the patient has anemia. Now you go and examine. We told the patient has a kidney disease. Now you go and examine. Patient has diabetes. Take any history and examination, find out what he has. So obviously, diabetes is so important, but is never found its way into the exam hall in UG or PG. I think we must have findings. So if you see a diabetic patient and ask for three macrovascular complications, comorbidities, two comorbidities, hypertension, cholesterol, and then the other things that you need, you probably are going to do a lot more good in the outside world. Similarly, HIV was very much ignored. So we put lab investigation interpretation and what we call as clinical problem solving in the exam hall, where we gave a patient came with a history of 2 weeks history of fever. On examination, he has a small splenomegaly. What is your diagnosis? What investigations would you do? So when we were asked to make clinical problem solving, we used to sit and quickly write some 10 problems and give, and then that would be printed. And then that's how we held our exams in Manipal. Now, what is the downside of investigations? Incidental abnormalities. For example, cervical spondylosis. Somebody comes with neck pain. Over the age of 50, 55, everybody will have some changes in the cervical spine. That doesn't mean that they have a disease and the patient gets very diseases. At times, this prolapse can be asymptomatic. Then we know a lot of incidentalomas that can come in endocrinology where you see something, but it's actually not important to you. And renal artery stenosis causing flash pulmonary edema is not always cause and effect because in the older age group, renal artery stenosis is common. And if you go and tackle the renal artery stenosis and hope that the flash pulmonary edema will not come, it's not right because there are some criteria for looking at that renal artery stenosis also. So the presence of some abnormality doesn't mean causation, doesn't mean disease. Conditions for which there are no investigations to prove. For example, Parkinson's, amyotrophic lateral sclerosis, Bell's palsy, epilepsy. Remember, nothing works. Okay, only the EEG sensitivity is only 40%. And that is also closer to your seizure. Where is the investigation to prove any of this? These are all completely clinical diagnosis to this day. Now look at this. 65-year-old diabetic hypertensive comes with vomiting and vertigo with inability to walk steadily since 10 a.m. today. The neurologist makes a diagnosis of a stroke and MRI is done. MRI is normal. Now what? Please remember there are MRI negative strokes, especially in the posterior circulation. The proportion of MRI negative strokes in the posterior circulation to anterior circulation is about 4 or 5 is to 1. So when you do an MRI and you don't find something, but you're looking at a 65-year-old with diabetic hypertensive who has every reason to get a stroke, please don't ignore it. Probably this patient will require an aspirin and a statin through life if they have not been already on. So what I'm trying to say is, if you want to use investigations, please understand their limitations also. Where investigations are mislead. Oh, this I could have filled 3 slides on it. Pseudohyponatremia. Many times your diabetic patients with high sugar, people are putting 3% saline on them without calculating for the pseudohyponatremia because of the high sugar. Urea is high in a GI bleed. That there's a disproportionate rise in urea compared to the creatinine. That's sometimes a clue for GI bleed. High total count without infection in dehydration, DKA, and thalassemia. All these things we know. In thalassemia, the larger RBCs are counted as WBCs by the counter, and then in dehydration and DKA, it's something else. In a DKA, more than 25,000 is probably when you would suspect an infection. Amylase can be high in DKA, SANS without pancreatitis. Urine pus cells, which is always celebrated and treated all over, do not mean much. It could be even bad collection. If the patient does not have symptoms, we are not supposed to treat. Asymptomatic bacteriuria doesn't require treatment except in those 3 conditions, pregnancy, transplant, that you all know. Echo can miss an endocarditis. You probably require a TEE, isn't it? A transthoracic echo will miss, can miss. Coronary angio misses the vulnerable plaque. So many times you're seeing a 50% block at the coronary angio on one end, and you're seeing a 90% block, and you're going after the 90%. The 90% may be vulnerable plaque, which will rupture and which can cause an MI. So remember, the coronary angiogram only shows you the lumen. It does not show you the wall. And the wall is where the vulnerable plaque is sitting. And so many times our investigation, the way we look at them should be, correct, so that we don't miss the diagnosis and we don't interpret them wrongly. And of course, microvascular disease in the coronary circulation is completely missed by the angiogram, which is more showing epicardial arteries. And this list can go on. There are so many examples in medicine. I actually adjusted the lines. I thought enough, and then I came out of it. Where normal values are not needed. For example, if you go after investigation, how many COPD patients have been given a lot of oxygen, pushed into carbon dioxide narcosis, and then come to us needing intubation? Because you think the oxygen must be 95%, whereas your target in COPD is only in 88 to 92. The bicarbonate and pH targets in DKA. How many DKA patients have been pushed bicarb without looking at the pH, and unless the pH is less than 6.9, nobody does it. But this is not interpreted or valued at all. The platelet targets in chronic ITP are never 1 lakh. You happily walk away with a count of 30 or 50,000 without bleeding, which is fine. You don't have to give your steroids and push that platelet count to 1.5 lakhs. Many times you will find ejection fraction in patients with DCM 25, 30. They are sitting and talking to you. Now, should you get scared of them? No. This ejection fraction is a number. You have to go with the patient's symptomatology and then think whether you need to really up your drugs or not. So remember, the number doesn't define the patient. So an investigation is a number, whereas clinical examination is something else. And of course, the theory behind all investigations and their interpretation is very, very important to you. In Chennai, where I work, the PET scan is the ultimate. For everything, at the drop of a hat, people go and do PET scans, okay? And they think it's for malignancy. They think it's you have got a cancer once you have it. But there are many other conditions where you can get a PET scan positive. The other day, somebody presented in one of our city physicians group a patient with sarcoid who had a PET scan positive. You can get it in tuberculosis. It only shows you avid uptake of FDG. It doesn't tell you it's a malignancy. Abscesses can have a positive PET scan. Now, if you do not recognize this fact, then you would call every abscess, every inflammatory condition as a malignancy. So, when we do the PET scan, we must understand what it is trying to tell us instead of just going for one size fits all kind of thing. PET scan positive means malignancy. Now, we had a PET scan negative PUO. We had one patient who had gone with PUO all around the place, worked out everything, including a PET scan. Then he landed up, he said, PET scan also negative. Now what to do? He doesn't have a malignancy. Does he have an infection? Just a cardiac auscultation showed a beautiful aortic murmur. He had an infective endocarditis on the echo. And why would the PET scan show you an infective endocarditis? It did not. So remember that many times you must understand the limitations or the positive and negative of what you're trying to do. ECG is one area where, there are so many ifs and buts. You all know the pseudo-infarction patterns of early repolarization, pericarditis, LPBB or Scarbosa's criteria, and the COPD showing the QS pattern in V1 to V3. These are all pseudo-infarctions. And if you go and call them as infarctions, I remember one of my uncles being put in a room years ago with a pseudo-infarction, with an early repolarization, awaiting a heart attack. He was sitting in a hospital. He was made to sit in a hospital, waiting for a heart attack to happen because people thought he had an MI instead of an early repolarization. And of course, the dangerous misses where Wellens can be, ECG can be normal, isn't it? So that can come later. And the D winter sign that we all miss. And the first ECG being normal in an MI. It happened in my life where I went with a patient at 4 o'clock in the morning, one of my relatives who had a definite MI. We had no doubts. He had the way patients describe the MI. Today also I met a patient with MI who said that he felt a ton of bricks was sitting on his chest. Okay. People say an elephant's foot is on the chest. The crushing, the compression of the MI, which is what this patient told me in Manipal at 4 a.m. one morning, that he definitely had some crushing pain in the front of his chest. The first ECG, totally normal. Totally normal. The cardiologist who stood with me said, Madam, this is an MI. Take one more ECG after half an hour. The second ECG showed a through and through infarct. So if you do not understand that the ECG can be either missing or overdiagnosing, we would go back and forth on these things. The big ID debate is always infection or colonization. Many times, every bug that is coming out of the body is to be swatted and killed. This is what is our policy. And when we give antibiotic for everything, you grow something in the respiratory thing, okay, put some antibiotic. You grow candida in the lung, you go and attack it. So these kind of things happen all the time without understanding that you must colonized. Once you put them in the ICU, every tract of everybody is colonized. So unless you know to interpret that culture report, you would always be giving lots of antibiotic, tons of antibiotic, making resistance very, very common. So remember that the culture showing a bacteria is not infection. Now, this is a problem that I think Sanket remembers very well when we were running our study and entertainment group in Manipal, which we ran for nearly 5 years. We had this problem put up in that over enthusiastic aunt who goes to a mall and gets one ANA test, and she complains of some aches and pains, which is always there, and her ANA is positive. So she's scared and she calls you, and this test has a 95% sensitivity for detecting SLE. What is their chance of having SLE? I remember Sanket telling, ask your aunt not to go to any mall and get tested. So please understand that what we are telling is 95% is in people who have SLE, not in your general population, because there is something called pretest probability, isn't it? What is the probability of your aunt at 65 years with having some vague aches and pains, having an SLE, okay, with nothing else? Just out of curiosity, she goes and does. And remember, if you calculate, with the general prevalence, your this thing chance of this test being right would be very, very negligible. So that's why we said, this is from a WhatsApp group that I wrote, it's garbage in and garbage out. So if you don't know how to interpret your investigations, you will be landing up with all kinds of trouble, because you will be diagnosing diseases that are not there because your investigation said it is positive. So if you want to use investigations, you master their sensitivity and specificity, and then you use them. Where ignoring investigations can make you look like a complete fool. I had a patient with vomiting due to pregnancy, multiple investigations, including a gastroscopy done. Patient was an unmarried female who did not want to tell her LMP, and this happened. I saw an RA patient undergo an angiogram. I was wondering how they did an angiogram at the wrist without looking at that wrist, which is completely frozen. So this also happens in real life. And this is something that I took from the newspaper, which talks about a middle-aged man. It's a funny story of a middle-aged man, and he came for a lumbar disc prolapse, and then casually his chest X-ray showed one lesion. And so immediately one CT scan was done. CT scan was normal, but the pulmonologist was called. And as you can see here, he calls him, he was like CMP, confused mass of protoplasm, spinal surgeon, internist, and pulmonologist all had a serious discussion. He's posted for a bronchoscopy the next day. And then the old man, who's the director of the hospital, just comes for a round. And to reassure the patient, he says, don't worry, tomorrow's bronchoscopy will tell you the diagnosis, and puts his hand on his back. And then he feels some round thing. And that turned out to be a lipoma. So not examining this patient would make you look like a complete fool. This happens all the time. If you rely only on investigations, this is what can happen to us. Plus, the patient is dynamic. The patient changes, especially in the ICU. Every day the patient changes. Can you keep on doing these investigations every day, all the time? You cannot. Then this trial, the process trial in septic shock, showed that the clinician's judgment was as good as investigation-based fluid resuscitation in septic shock. So remember that the clinician's judgment is very important in a dynamic patient where things are changing. New RALs, new V's, new dyspnea can occur in an ICU patient, and we cannot keep on investigating without thinking. And which investigation is going to show you your V's? Which investigation? There is no investigation for a bronchial asthma or a V's. It's a completely clinical diagnosis and an aspiration. Okay. Everything, you cannot CT the fellow every day, right? A dull and drowsy patient in the ICU must be picked up because he could be having anything. Okay. And these things keep changing again. DVT can be under the covers if you just open the limbs. I remember discovering what DVT like that. Seizures in the ICU are often missed. All these are dynamic changes. So we really cannot depend on investigations to make this diagnosis. So ignoring clinical examination is not at all a solution. It's like throwing the baby out with the bathwater. It's a brilliant chapter in your latest Harrison, written by Abraham Verghese, who is famous for all his books, including The Covenant of Water, which is a brilliant book. I would suggest that you read. And there's so much medicine in The Covenant of Water that I really enjoyed it as a fiction and as, the medical aspect of it. And all his books are very nice. And he's written a fantastic thing. And he has written about this Sherlock Holmes based, the Joe Bell kind of story that I think you all know. I would ask you to read your Harrison to see this. But what I want you to show is the likelihood ratio of each clinical finding he has given. So if there is edema, what is the likelihood that, it is present, what this diagnosis is present or not, etc. It's very nice to go through this. So if you rely on clinical medicine, again, master the sensitivity and specificity of that particular finding. So life has actually not become simple for us. Life has become complicated. Many times we over investigated. This is from Atul Gawande's article in the New Yorker. You can see the date. You can go back to this article and read it. It's a brilliant article on overkill, where he says in the US, so many medical things are being done. I don't want to read this to you. He talks about how many patients undergo unnecessary investigations, unnecessary, treatments, which are not at all needed. And why do we do this overkill? Because we are scared. We think if we miss something, it haunts us. So that is why. The point is that we cannot be so unsure of ourselves. Somewhere we have to get the confidence to say, this is it. The other thing that pushes us towards investigations, the patient trusts investigations beyond us. They don't trust us. How many times have you been shoved a sheaf of papers under your nose as soon as the patient sits down? He says, these are my tests. Then I take it aside and put it and say, I don't want to look at your tests. I want to talk to you. There's an article I wrote in the Hindu long time ago. It's in 2005. Can you imagine? So I told a personal example. I wrote in defense of good doctors because everybody said doctors are bad. They are, cheats and they are taking off money, etc., etc. So I gave an example of how my own maid came to me with a gastritis and I prescribed her something without charging, gave her the medicine from the samples I had. But then she did not trust me. She went and got one ultrasound, and that ultrasound showed some ovarian cyst. And for that, she came to me asking me for advice. So this is what happens because patients also don't trust us at all nowadays. Whereas I remember I took my mother for a seizure to the top neurologist in Mumbai, Dr. Wadia. And again, I did the same mistake that my patients do today. I put the CT scan in front of him and said, Sir, this is my mother's CT scan. He took it aside. I learned from him to do that, to take it and put it aside and then say, I want to examine. And then I saw how he examined the patient, my mother, in 10 minutes flat, right up to everything he did. From first 10 years now to everything he finished in 10 minutes flat. Then he asked me for the CT scan. So when we ask ourselves this question, clinical examination and or investigations, it's always and investigations. And why we say this is because investigation without clinical examination is like fishing in the ocean for one fish. Where will you fish? What are you going to do? Clinical examination tells you where to go and fish. So it gives you the direction and makes it easier for you to focus on that particular investigation. So always the direction is important. Clinical examination to investigation, not investigation to clinical examination, which is what most postgraduates do these days, that they first look at one investigation, then look at patient. Wrong direction. Always take history, examine, then investigation. You will easily get the diagnosis. And many times you will save the patient a lot of money because this varicella zoster is investigated with electrocardiography, cardiac enzymes, chest x-ray, everything, okay, without looking at the patient. So you save your patient a lot of money by clinical examination. Coming to the last part of this talk, where we are very scared, the last bastion, that is decision making and analysis. We think that the most important game changer in prognosis is a doctor who thinks about our patient. And all of us in medicine and allied specialties are very proud of our analytical skills. Let's look at why analysis is important. Again, this is a patient from our practice only. 50-year-old man with vomiting and weight loss of 1 month duration, treated as gastritis, not better. CT scan was done. In this city, more than a scopy, a CT scan is preferred. CT scan was done. It showed some narrowing the ascending colon. He was diagnosed as CA colon. Immediately CA, everything is done for him. But when he came to us, I said, see, why would he vomit if he has a CA colon? Why is he going to vomit? Let's have some common sense. So we went back to gastroscopy. But gastroscopy showed only mild gastritis, and the man was throwing up everything. One thing that I made out when he came was that when I examined his abdomen, I found striae on it. And I asked him 100 times, did you take anything else? No, nothing. I lost weight, so all these striae came. So I also thought maybe. Then one day I found that his wife was standing next to him, and I asked her. Then she told that every day on his way to the factory, because he used to have some aches and pains and some cold and cough, he used to take from the pharmacy steroids. Every day he took. And then, like my previous patient, he stopped it for some reason 1 week ago, 1 month ago, and that's when he got the vomiting. So the history, the wife gave that history, and that history was important. But one day before she gave the history, I lost patience and sent a steroid level because I thought something is wrong here, and the steroid level was abysmally low. This again shows you that you must analyze. See, just because the fellow is vomiting and your CT scan showed something in the colon, we even did a colonoscopy, we didn't show anything. So, what I am saying is, if we go on going where the investigations take you, you will never arrive at where it is right. You would probably go in the wrong direction because you stick with your patient. Patient came to you with vomiting, think of the causes of vomiting, rule them out one by one. And this case, it happened to be a steroid withdrawal. Again, a brilliant article by Siddharth Mukherjee. If you have not read The Gene, you should read it. It's a fantastically written book showing you the progress on genetics over decades. So this is an article where he talks about AI versus MD. Will the artificial intelligence completely replace us as MD physicians? What if the diagnosis is automated and the last bastion, that is our thinking, is taken away from us? So which specialties will be replaced? If you read his article, he will tell you it is the image-based specialties that will go first. So we are still last in the line. We won't go out fast. Okay. So it's a radiologist and the dermatologist and the pathologist who will probably go out first because the AI would do consistently better than them because it's good at pattern recognition, good at machine learning. But what about us? This is the chat GPT era. Anytime you want a diagnosis, go to chat GPT, ask it, and it will tell you the diagnosis. So are we going to be replaced by chat GPT? I don't think so. I don't think so. Because chat GPT works on the question you ask. Sometimes I feel we must change the exam system completely and not ask for answers. But we must make an exam where a person is able to give a good question. Why don't we change it? Because now it's our ability to ask questions that is important. The answers are all available. So it's us who have to change the way we look at life, the way we look at clinical medicine, and then we have to probably change the way we teach and the way we learn. And so I feel that asking the right question is more important than getting the answer because the answer is easily available these days. What is irreplaceable in clinical medicine is the human touch. I remember a patient I saw in Udupi Hospital who met me after 5 years and told me that, doctor, you remember I had typhoid. Who remembers which patient had typhoid? Obviously, I know nothing about him. But he told me that you put your hand on my back and told me you will be all right. That's all he remembered. That's all he remembered. He didn't remember that I struggled to make a diagnosis of typhoid and how intelligent I was to make that. Nothing. He remembered that I consoled him. So this is what is irreplaceable in clinical examination. Rounds then and rounds now, most often chart rounds is done without the patient and we spend very little time with the patient. So patient doesn't feel important. To be at the bedside, to behave with dignity and compassion with our patients and talking to patients is very important because many times patients say, they did not even look at my face. He did not even talk one word to me. He did not even touch me. Many patients have told me that the doctor never touched me, doctor. What kind of a doctor is he? He never examined me. This happens. And breaking bad news, when we stand outside the ICU or when we have to announce a malignancy, we have to think that there are human beings on the other side. Now, this is not a profession where you're dealing with some microbes. You're dealing with human beings as clinicians, and you must know how to behave. Plus, we must all have that empathy. If you have ever been a patient in your life, you will understand how much it means for them to see a doctor. So, like again, this is again from Abraham Verghese, who talks about how the patient feels important and listened to, and physical examination establishes trust, and talking to allays anxiety. So, right from Hippocrates, who said that cure sometimes, treat often, but comfort always, To Hutchison's prayer, one of the best prayers ever. He says, from inability to leave well alone, we go and poke our nose and do all kinds of things. From too much zeal for what is new and contempt for what is old. Something is old, we give up. From putting knowledge before wisdom, science before art, cleverness before common sense. The most important thing in medicine is common sense. So that is the most important quality that we should all have, and we should keep on developing that. It's not that we're all born with it, we have to develop. From treating patients as cases, from making the cure of the disease more grievous than its endurance. Many times this happens in cancer chemotherapy. Good Lord, deliver us. So to conclude, clinical examination is here to stay forever as a very useful tool in diagnosis and decision making. But we need to relook at which aspects are important and emphasize them in our training of UGs and PGs. We should include investigations, interpretation, and training. Very, very important. We were on the other side. We were always doing only clinical examination. We have to include investigation, but it should always follow clinical examination. But training of interpretation and investigations is crucial for us to be able to use them. AI 2, ChatGPT 2 is a very good servant. Many times I've used ChatGPT, I've used AI Perplexity, I use all of them. But when they go wrong, I always tell them, ChatGPT, you are wrong. You better go and reconsider. And he says, oh, I'm sorry. And it goes back. So many times you can use this AI as a good servant. The human element in medicine can never be replaced. So I don't think anything can console the way we do. And we should have that empathy for that patient. And that is why I feel clinical examination will never die. It is not the beginning of the end. Thank you.
Thank you, ma'am. It was very useful, and I think I learned from you only that the secret of good medicine is not about connecting dots, it's actually making the dots.
Yeah.
So it's very important. We have to make it properly, and it comes through only history examination. If that step is missed, I think we miss a lot. Thank you. This was very relevant. I think I can relate to few cases what we have seen in MedCAS.
Yeah.
Yeah.
Yes, I did.
Thank you.
Thank you. Thank you very much. Right.